Okay, today we're talking with Greg Starbird, CEO of the HealthStore Foundation. Welcome, and thank you for being with us today.
You're welcome. Thank you for having me.
So, the HealthStore Foundation is a 501c3 nonprofit, right?
Yes.
Yet you've opted for a market-based franchise model to distribute medicines in the developing world. I wonder if you could explain a bit more about how you sustain your model, if it's mainly funded by donations to the nonprofit or by revenue generated by the franchisees.
So historically, it's been a combination, and it's a good question. Our franchisees are for-profit, very small-scale private medical clinics in Africa. So each clinic is owned and operated by a local nurse who invests borrowed money into starting this clinic and then sells products and services for a profit to her local community. So at the local clinic level, it's straightforwardly a multi-unit retail network seeking to have profitable franchised outlets. Like you said, at the corporate level, we have operated as a nonprofit both in the U.S. and in Kenya. Our franchisor in Kenya has historically been a nonprofit entity, which is predominantly funded by grants and donations. We are making a shift shortly to use a for-profit franchisor vehicle in Kenya and to shift any necessary subsidies to be part of revenue to franchisees instead of top-down grants. So that's a shift we can talk more about later if you like.
Okay. But in the future, you're planning to have a balance of the two sources of revenue?
Well, we believe that there will always be subsidies in treating infectious diseases in the developing world. So serving people at the base of the pyramid, there will always, in the U.S. or elsewhere, we think that there will be subsidies involved. The question is just how to route those subsidies. So far, we've essentially used those to insulate our franchisees from certain costs. So we've collected donations from grantors and donors, and we've housed those in a nonprofit umbrella organization that can then disperse those to franchisees or pay costs on behalf of franchisees and so on. Instead, we'd rather we want to create an opportunity, a pipeline, if you will, through which donors can have a much more transparent, accountable, and efficient way than they can currently through us or otherwise to subsidize health care for the poor in the developing world. And in so doing, we'll be able to transition fairly smoothly to a for-profit franchisor vehicle in Kenya that will be funded from bottom-up revenue earned from franchisees instead of from top-down revenue directly from donors.
Okay. And in your presentation today, you spoke with us at the William Davidson Institute earlier. You talked a lot about the challenges of operating as a business, the small margins, branding issues, franchisees sometimes not complying with the rules. I wondered why you decided on a market-based model as a nonprofit rather than just using donations to purchase medicines and give them away for free.
Well, largely because we observe that there's already in a place like Kenya, there's a fairly robust market for private health care. So the way that a lot of people get their health care, especially for a short list of conditions like malaria, is to visit their local private dispensary or chemist or pharmacy or clinic. So we wanted to invent a solution to maintain quality standards in such an environment where often geographical access is there. There's somewhere for someone to walk to get something called health care, but quality standards are so low, the prevailing quality standards are so low in these environments. We thought, couldn't we invent a profitable model for to be able to be franchised to local nurses or other health workers to distribute medicine and maintain those quality standards?
And were you concerned that if you had just operated as a nonprofit and gone into the country and set up shops with free medicines bought by donations from your nonprofit in the U.S., you would have pushed local medicine sellers out of business or harmed the local economy in some way?
Yeah, I mean, I think that the way to maintain standards would not, in our view, I guess theoretically it would be possible to just source good quality drugs and give them away, but it would be much more powerful and responsive to local needs, in our view, to set up a system that is a business opportunity for local people who can respond and permanently be fixtures in their local community, profitably. So the permanence comes from profitability, and that business would be an opportunity too valuable for them to give up or to risk by breaking certain rules. So we condition their enjoyment of these little businesses, these little clinics, on their following certain standards and rules that we establish. Things that relate to drug quality, yes, but also related to everything about record keeping, marketing, customer service, signage, equipment standards, cleanliness and hygiene standards, and so on. So all the standards that are normally so low in as they exist in normal chemists and many clinics and so on around there, we think we can raise by creating this business opportunity rather than just giving away drugs.
And since you've been focusing on trying to get local people involved and setting up profitable businesses around selling essential medicines, have you been concerned that, was your concern for the sustainability in the long term a reason why you've been trying to move away from the subsidized model from your nonprofit in Kenya?
That has not been the primary concern. I would say that the primary driver of our restructuring that I described earlier is that our mission is not only to maintain standards but also to scale a network widely. To scale a network widely requires robust unit economics and a franchisor who is incentivized in a way that's aligned with franchisee incentives. So we want to be able to have a profitable franchise company servicing profitable franchisees, and we want that whole thing to be able to be funded by investors, social investors, if you will, that are interested in that sector, even with all its risks. And even though that whole business will involve subsidies from the bottom up, we believe that's normal for private healthcare even in the U.S.
Okay. Just to be clear, you don't think there's any possibility of making attractive profit as a non-subsidized business doing drug retailing and distribution in the base of the pyramid countries?
Well, I wouldn't want to make such a general statement. I think there are parts of this, parts of the value chain and the retail business with regards to drugs and medicines and healthcare-related goods and services that can be run profitably. I think that the reality is the ecosystem in which such a business exists is one in which, again, there are poor customers, but also there are serious constraints in terms of road conditions and other things. So just a simple example is, obviously, if you're driving 50 kilometers on a dirt road rather than one, you're going to burn a lot more gas, and if you have to drive that distance to deliver drugs or other things to a facility, then the question becomes, can people, if in your theory that it could be profitable, or the theory you're asking me to comment on, could people at the end of the chain afford to bear those full costs? And the answer seems to be that although there's a market for private health care, as I said before, in these places, people don't bear those costs very well. The prevailing prices reflect the delivery of substandard products and products of unreliable quality and services of unreliable quality. So what we want to do is produce a situation where, again, standards are maintained even in those remote locations. I don't think that can be done very well in a very full-fledged manner for a very high percentage of the population profitably, even if you could siphon off some parts of it that are profitable. And by the way, I'm only talking about the markets that I'm familiar with in Africa. I really have no comment on South America or Asia or other places where these economies could be very different, the fluidity between rich and poor could be different, and so on.
Okay. A related question. In your presentation today, you made the point that U.S. pharmacies, actually someone made the question to you that since U.S. pharmacies make a lot of their money from the sale of non-medical items, that may be something that you should consider doing with your franchisees. And in your response, you mentioned that you were looking for higher margin products that your franchisees could sell along with the medicines to become more profitable, but they couldn't sell things like Coke or cigarettes you kind of joked about. Yet U.S. pharmacies do sell those things alongside medicines, and I wondered, is your reluctance to open that door due to like distribution issues, regulatory issues in the countries, or because you don't want to dilute your brand by opening the door to non-health care related items, or Is it that, from a public health standpoint, you disapprove of those products because they're damaging?
A combination. I think largely a regulatory question. Certainly, in a situation where things are, you know, clearly deleterious to public health, we would not want to get involved in that, such as cigarettes. But we would probably be willing, theoretically, to look at a broader list of over-the-counter items if we had the leeway to sell them. And different countries have different regulations on that. I would certainly love it if any NextBillion readers or viewers would email or call us with ideas on over-the-counter products, even ones that they are thinking of designing or could be designed to fit these contexts. It's exciting to see people try to develop new, radically affordable products for the base of the pyramid, and we've encountered some that could be relevant. Many of them have price points or other attributes that are difficult for us to integrate, but we're wide open to ideas on this front. We have empty shelf space or available shelf space in our clinics for such products. We have the ability to train a large number of people to promote those products, and if they have to do with nutrition or hygiene or anything that can fit within our brand and the regulations, we could do some tests to see if they're viable.
Okay, so as it stands, you would only be open to products that have some sort of a health promotional bend.
Well, I would want something that fits with our brand promise of our mission of improving access to high quality essential drugs and basic healthcare and prevention services, but also our broader brand promise of improving the well-being and so on of local communities. So that could be much broader than directly preventive or hygiene products, but we have to be able to make the case to regulators that this is acceptable.
Okay. And I mean, theoretically, if the regulatory situation were to change in a country where you do business, and products, I mean, that weren't health or care related came along that had such a high margin that it would dramatically increase your franchisees' profitability, would you be open to, becoming more of a general store / healthcare business?
Yes, but for sure. But again, I'm not sure I agree with the premise of the question, because keep in mind there's a barrier to entry for what a clinic can sell, and we're we're beyond that barrier. We are officially licensed clinics with well-trained and officially credentialed people. Whereas if there's a high margin item that sort of anyone can access and sell from any shop, I think quickly it will become not a high margin item if the market is allowed to work in a normal fashion, which is fine. So I think, we're looking for something in a sweet spot that it's not necessarily high margin, but it could be high volume. And even a high volume item would be great because it would attract a lot of people. Maybe it's something that's attractive to children, for example. Children want to come to the clinic for something that's low cost, low margin, and can tie in and allow them to enter this environment where their mother came to receive prenatal care. After the child was born, the child hopefully was vaccinated at our clinic. If the child gets sick, the mother brings it to the clinic. The child's bed net that he or she sleeps under is from our clinic. So it's not that we're trying to be a comprehensive facility, but we are involved in the quality of life and access to healthcare at a very local level. So something that can introduce people to that brand, CFW brand, representing those things, even if it's low margin, high volume, would be very much of interest to us.
Okay. Correct me if I'm wrong, but I think you mentioned in your presentation that franchisees pay $5,000 to purchase a HealthStore franchise. Is that the case?
It costs approximately $5,000 to open one of our typical clinics, which covers, all the initial inventory, outfitting a typical retail rented storefront space to become a clinic according to our specifications, fixtures, furnitures, equipment, and so on.
Okay, and how did you arrive at that price point? Was that just to cover costs, or is it?
Yeah, so a franchisee would be usually borrowing that money to set up a clinic, and we want to have a very low cost format that we can open many locations. So whereas we might say, well, wouldn't it be nice to have solar panels and doctors and a twisty slide for children in the front and drill a borehole well next to the clinic and offer water and all these things. We can look at each of those things individually, but everything that we add to the clinic startup costs is an impediment to getting financing and to scaling the business to a certain extent. we have to balance that with unit economic profitability. And so it's not like we don't want to add anything. We want to add things that in the end make a compelling case for many nurses to join our system as franchisees, for lenders to lend to our franchisees, for suppliers to supply our franchisees, and so on.
Okay. Because the cost is low, but in dollar-a-day communities, I mean, do you find that it's hard to find someone who has access to that much money?
Yes, and normal lenders find, say, a $5,000 to $10,000 loan. I can't speak for normal lenders, but our experience is they have found it sort of too low. It's bigger than a microloan, and it's smaller, and these particular locations are more remote for them to want to lend to them. It's too much of a cost to deal with collections on a bunch of geographically dispersed outlets and so on. Our nurses have no formal credit history usually. They don't normally have collateral in a normal sense. So we have so far tried several modes of financing in response. We've collected donor money and been the lender ourselves. We've acted as a guarantor to banks to lend to franchisees. We're just now exploring, with regards to inventory management, some crowdsourced funding online, like through Kiva Zip. So those are some of the examples of ways we've tried to get around this financing obstacle.
So I understand that the HealthStore Foundation network operates two types of outlets: the basic drug shops, and then that are operated by community health workers, and clinics owned by nurses who provide essential medicines and some basic primary care. Have you found that either of those is more profitable and or more difficult to sustain?
Generally speaking, the clinics have access and authority to be able to provide not only some services but also a broader range of products. So they have a leg up in terms of potential revenue and scope of services and products, but it also means we need a nurse. So in my opinion, in the long term, we need to think about all sorts of different formats, and we've had both shops and clinics without labs, clinics with labs. In Rwanda now we have health posts, which are more in conformity to the Rwanda tiered healthcare system and tie into the public system. So there's different formats that can be developed, and the formats have to be responsive to the local environment of what can be profitable and scalable.
We are out of time, so would you like to add anything?
No, thank you very much for having me on this. And again, I'd love comments on your blog or emails directly to me. Greg@healthstore.org is my email address, and we're open to lots of innovative ideas, outside the box ways of thinking, critiques of anything I've said. We love the idea of being in conversation with this emerging community of people thinking about these important issues.
Well, great. Thank you so much for your time today, and we really appreciate it.